Kia ora Peter and kia ora tātou. Many thanks for the invitation to speak today. Ngā mihi kia ki tō kaumātua mō te awhi, mō te karakia, mō tēnei zui. I love that word now. You'll notice on my first slide, I haven't put down that I represent any organisation. So this is a very personal view. I've been given 10 minutes to try and address Māori health based on our experience with COVID. So it's going to be short, sharp and very personal based on my experience as a GP in South Auckland and my research within the University of Auckland. So just to keep in mind that it is lessons from the COVID-19 experience over the last 18 months and how we can apply that in that long-term condition space. So just as we've had long-standing inequities with long-term conditions, we're experiencing inequities with this current pandemic. 30% of cases are Māori, despite the fact we make up 15% of the population. We are exposed to more of those wider determinants of health that make us at increased risk for the infection as well as long-term conditions. Things like poverty, access to healthcare that's timely and effective, including to vaccinations, as Rod's already pointed out. And given the lag in time that many of our young people had to wait before they were in the group 4 eligible for vaccination, we've had longer time to be exposed to misinformation. And so it's no surprise then that we have the lowest vaccination rates around Aotearoa, and modelling suggests we're at least 50% more likely to be hospitalised and dying from COVID, just as we see with long-term conditions. When we look at the other side of the tatiriti, so we're looking at that equity and being equal citizens within our own nation, if we look at the ability to be part of the decision-making, our advice is not always sought. And when it is sought, it might be ignored. And the fact is we're incredibly busy as Māori health leaders and public health experts and researchers and practitioners at the moment. And that speaks, I guess, to another big area of inequity, which is Māori health workforce. But that's another talk. And so we've had to step up. We've had to implement what we know works in our own communities and implement interventions that we think are going to fill the gap that currently exists in our health system. But even that's criticised, as we've seen with Matire Harwood and his commitment to his own community, trying to set up the border control to protect his community, and that's been created some outrage in media. So if we were to think about all of these things and line them up with the Y2575 principles that were outlined as part of the Waitangi claim, we can see there's not very good alignment, if I have to be honest. So if we look at outcomes and the fact that we've had such differences in outcomes for COVID, you know, this speaks to the fact that we're not being actively protected in our own nation. If we look at the fact that we do continue to experience the disadvantage of those wider determinants for poor health, this addresses the issues around equity, and that the ongoing inequities within society are going to impact on our health and well-being now and in the longer term. The health system responsiveness has not been the best, and I think this speaks to the idea of tino rangatiratanga and our ability to be part of the decision-making, part of the solution-making, and implementing those interventions in timely ways. And going further on the decision-making, you know, this really speaks to the fact that there hasn't been a good relationship or partnership with Māori in that. And as I said, really also talks to the fact that we don't have enough of a workforce to be able to be there because we're too busy getting on with things. But when we look at what Māori providers are doing, just getting on and implementing what they know works for their communities, providing good care, implementing the evidence, getting it into whānau's homes, we're creating options in that space. And that's the final principle of the Y2575 claim. And so my I guess, potential solution is to create a vaccine for the health system based on the evidence that we've seen with the COVID-19 that's going to address inequities and institutionalised racism, which has been my experience during this COVID-19 response. Just like we've seen with the vaccine development, we've had innovation, collaboration, lots of fantastic researchers coming together, putting it into practice, getting the evidence really quickly so that other nations can make really good decisions built into policy around their vaccines. So I think doing this in our own health system would be a good thing too for the collective good. Equally, it might be challenging for some people within our health system, and so it might hurt for a short time, but there are huge long-term benefits. And the idea of mandates, equally, I'd love to see something like that in our health system, it being mandated rather than being talked to, but not actually implemented. So how does the mRNA vaccine work? And I thought I'd apply some of the steps to the way that we could do similarly with applying and implementing Māori health research that's going to address and achieve equity in Aotearoa. So I've pinched this from a Michigan medical school, and I thought it was quite useful. And it talks about 3 steps: create, learn, and protect. So in the create space, the vaccine tells the cells to make the spike protein. So it's about teaching it. And so in the same way, I'd love to see us developing policy and a workforce that tells the health system that it needs to deliver interventions that achieve equity and are anti-racist, both in terms of actions, but also addressing any inaction that might create inequities as well. I think our system needs to be more open to sharing and scaling up initiatives that demonstrate equitable outcomes and has antibodies to those inequities in the same way that the vaccine does that within our own cells and body. Just my own experience in developing interventions for long-term conditions that we've been able to show have been effective, as we've all outlined, it's not taken up, it's not scaled up, and just those steps to be able to do that create major barriers for Māori health advancement. And then the final step that the vaccine takes is this idea of protecting us. And so I've pinched this from Ngāwiri, this idea of saving Māori lives, because if we know that if we get it right for Māori, that everybody's going to benefit. So what does this look like in practice? Well, I've taken the letters of mRNA and used that to try and think about simple ways of applying policy into the health system. As Rod's already talked about, having some kind of organisation sitting alongside the ministry, and I think these sorts of principles need to be in there as well. So the M stands for mana and mātauranga. So anything that we're doing should be mana enhancing the well-being of our whānau, communities, marae, hapu iwi. And we should also be using mātauranga, so those traditional ways of knowing, being, doing into practice. But mātauranga is also about understanding that kaupapa Māori research is equally about addressing the social justice issues, which we know have been long-standing. And so any idea about implementing things needs to take that into account. I think we need to have rangatiratanga. And as you would have seen, it's been defined as leaders who come from those communities being able to weave people together in wonderful ways, or in ways that achieve wonderful outcomes. So having rangatiratanga, having those people and those faces that come from the communities, as we've seen here in South Auckland with our vaccine program. We've got Māori doctors, Māori nurses, Māori community leaders, rangatahi, kaumātua. These are the faces that our people relate to. And so we need to build up and understand that it needs a different kind of workforce. It can't be just the same old who are delivering and implementing and understanding that these interventions are going to work. ngā rongoa is about weaving together the different things that are going to help people being well, and understanding that we can't just pick something up like a medication or a policy and pop it into practice if it's not going to work for our communities. And so this is just a picture of me from last Friday, going out and visiting people with COVID in their homes, getting on the phone, speaking to them, putting them at ease, and making them feel valued as they're going through this illness. But, you know, what is it that you need at this moment? And so we've been packing up our own cars to deliver kai, to deliver data so that they've got access to communication with the wider world outside of their homes, nappies, baby formula, medications, and addressing those questions so that they feel safe and are able to manage at home. We've also only had the one oximeter. So, you know, even though the Ministry of Health talks about their policy and the practice of delivering oximeters to all whānau, some of our whānau have been waiting 5 days to get there. So we've had to go out with the practice oximeter and vigorously wash it down in between each home because people want to know what their oxygen levels. They're seeing on the news that this is a major thing and determines how well or not they are. But finally, we need to inject a big fat dose of aroha into our health system. The work that we do as Māori providers, policymakers, practitioners is not just about ticking a box or completing a guideline. It is about having aroha for our own whānau because for me, I didn't have the opportunity to grow up with my grandparents, having them pass away from long-term conditions. My children get to spend the last 15 Christmases with their koro and kaumātua. So that's why I do the work that I do and why it's really important that everything we do should be about saving Māori lives. Noho ora mai.